So let me begin by introducing our speaker for today. He's actually, if you have done the American College of Lifestyle Medicine, the board review course, you would have met him as one of the co-presenters of the Positive Psychology chapter in the board review course. It's none other than Simon Mathews. He is a renowned psychologist and a leadership coach. He has particular interest in supporting leaders in healthcare. He is a fellow of both the American College as well as the Australasian Society of Lifestyle Medicine. Simon is both certified in health coaching and lifestyle medicine and is a professional certified coach with ICF. He's a lead coach and faculty with Well Coaches School of Coaching, which is based in US, Australia, and Singapore. And he's an adjunct lecturer at Avondale University Lifestyle Medicine and Health Research Center. In addition to that, Simon is a director of the US not-for-profit Global Positive Health Institute. He's a member of the International Advisory Board of the Romanian Society of Lifestyle Medicine. He's also a member of the Scientific Advisory Board for the Institute for Healthier Living, Abu Dhabi. He has done many publications in both professional journals and books, and he's here to talk on the most important topic that is quite a challenging area when it comes to lifestyle medicine practice, which is how to bring about health behavior change. And to talk about the principles of health behavior change, let me invite Simon Mathews to take over. Over to you, Simon.
Wonderful. Thank you very much. Thank you, Rukshanie. Appreciate it. Good afternoon, everybody. It's wonderful to be here. I'm going to start sharing my screen shortly. First of all, thank you. I've just learned that it's a holiday weekend in Sri Lanka. In fact, there's two holidays, I believe, one for the full moon and one for the birthday of the Prophet Muhammad. So, but thank you for taking the time on a holiday weekend to come and explore principles of health behaviour change. And for those of you who are enjoying the holiday weekend and are going to watch this replayed, then you know, my greetings to you as well. And I hope you take something useful out of it. I'm going to start sharing my screen. The other thing that I'm going to do is invite you to type a question in the chat at any time. Please don't feel like you need to wait for a particular moment. If something comes to mind that you want to understand more, just let me know in the chat and I'll be happy to pause and answer that, or maybe answer it within a short period of time. I'm also going to invite you to interact with me in the chat as well. And let me, while I'm sorting out the screen sharing, let me invite you to type in the chat. If I had a scale that went from 0 to 10 that measured how much energy and enthusiasm you have right now to be here, 10's the highest. No judgment, just type a number for me in the chat right now that reflects how much energy and enthusiasm you've got to be here. And I'm going to set up the screen share while you do that. All right. Here we go. There we go. I think that should be. I think that should be right. Okay. All right. Let's see. A few of you. Okay. A few of you have said 10 out of 10. Wonderful. 9 out of 10. Wonderful. All right. Jonathan. No bueno. But glad to see you. Glad to see you here. Fabulous. All right. Well, we're going to dive right in, and look at the principles of health behaviour change. I have no disclosures to make about anything. There are two learning outcomes that I've got for this presentation. One is for you to be able to name some key components of all theories of health behaviour change, regardless of which theory it is, and secondly, to have some ideas about how to apply those. Rukshanie, I'm getting some audio feedback from somewhere. I'm not sure where it is, but I wonder whether you might be able to just look into that. Thank you. Yeah, that's stopped now. Wonderful. So that's where we're going. Now, how many theories of health behaviour change do you think there are? I'd love you to just type a number in the chat right now. Do you think, for example, there are somewhere between 1 and 25 theories? Or do you think there might be somewhere between 26 and 50 theories? Or do you think there might be somewhere between 51 and 75 theories? Or do you think there might be somewhere between 76 and 100 theories? And it's very important that you know this, because there will be a test at the end on each. No, I'm only joking. We're not going to have a test to see what you know about all those theories. Well, here's I'm going to share with you, Jonathan, more than 76. Okay, Samandika 1 to 25, but won't be surprised if it's more. Samandika, you won't be surprised then. It is certainly more than that. There's a 26 to 50. Yes, 1 to 25. Okay. Well, let me share some good news with you. This is one of my favourite academic publications of all time. It's a paper that was published not quite 10 years ago, and it was a scoping review of theories of health behaviour change. And you can see a red arrow I've put on the abstract there. The authors say in the abstract, we identified 82 theories of behavioural change. 82. So that's pretty amazing. But here's the really funny thing. For those of you who have ever published an academic paper, or published something in a journal, think about how long it usually takes from the time you start writing until the time you finish writing. It's often a period of some weeks, sometimes even some months. So we can imagine that the same passage of time might have occurred here. By the time the authors got to write the conclusion, they said there were 83 theories of behavioural change. So we went from 82 to 83 within the space of one paper, which suggests, of course, that theories of behavioural change are being developed at such a rate that there's one being added every few weeks or months. And in fact, there are. So this was 2015. Since 2015, I'm also aware of, for example, the BJ Fogg behaviour change theory model, which is about 2019, I think. I'm aware of a wonderful theory called the busyness theory, which simply means you're more likely to be successful at behavioural change if you're already engaged in some other behavioural changes. There's another theory I'm aware of called the multi-attribute utility theory, which simply says you're going to make choices based on the medium to long-term value you see on the outcomes for those changes. So that's what, 83, 84. So I'm up to 86 already, and there's probably some more still. 86 theories of behavioural change. Do we need to know them all? Short answer, no, but there are some principles that are common to all of them. I'm going to show you the simplest theory of behavioural change. Now, to do this, I want to imagine, or I want you to imagine, in fact, I'm just going to ask you now, who would be prepared right now to do 100 push-ups? Just type yes. Just type a letter Y. If you would do 100 push-ups right now, for no, you're not going to get any reward for this. Jonathan, okay. Man, just recovering from the flu, and you're you're up for 100 push-ups. Okay, so okay, so a couple of you, interesting. So so you two have strong internal motivation. Let me now put an incentive on the table. I'm going to offer 1 Sri Lankan rupee to someone who will do 100 push-ups. Just type Y for yes if you will do this for 1 Sri Lankan rupee. Okay. What about 100 Sri Lankan rupees? Okay, there's someone who might do it for 100. What about 10,000 Sri Lankan rupees? Just type Y if you will if you will do this, do 100 push-ups for 10,000. Look at all the yeses coming now in the chat. What about 10 million Sri Lankan rupees? Will you do 100 push-ups now? Just type a Y for yes if you would do that. Look at how quickly those Ys are coming now. This is the simplest theory of behavioural change, an incentive. If I incentivize you enough to make a change, you will make that change. It's that simple. But here's the other side of it. What if I now remove that incentive and say, well, okay, I've given you 10,000 rupees to do 100 push-ups. Now I want you to do another 100, but I'm not going to give you anything. Are you still as excited about doing 100 push-ups? Probably not. Except for you, Dr. Asian. You've been excited about this all the way along. So the problem with external incentives is that they tend to work in the short term, but not in the longer term. Sometimes disincentive works as well. Disincentive, of course, is punishment, but also that tends to only work in the short term. If you're driving your car much faster than you should be, and you see a police car stopped on the side of the road up ahead, what do? Well, you probably slow down because you don't want to get a fine and you don't want to get points taken away from your license. But as soon as you go around a bend in the road and you can't see that police car anymore, you probably speed up again. So the disincentive works to shape your behaviour in the short term, but not in the long term. And one of the applications of health behaviour change, of course, is if you as a practitioner try and disincentivize your patient, if you try and say to your patient, if you keep smoking, then you will get lung cancer and die, you'll frighten your patient in the short term. But once that fear subsides, then they'll probably resume their previous behaviour. So these sorts of external incentives tend not to work in the long term. There are those 86 theories that we talked about. One of the major theories of health behaviour change is this one, the health belief model. Now, you probably know of this model without knowing that you know it. The health belief model is widely used in public health campaigns. And it's based on some principles like a person's perception of their susceptibility to a risk, how severe that risk is, what are the benefits they take for what are the benefits they receive if they take some action, what might get in the way. So, for example, if you walk into a bathroom and you see a sign on the wall with some hand washing instructions, this is probably based on the health belief model. What are the risks to you of not washing your hands? Well, spreading disease, both internally to yourself and others. What's a possible outcome from that? Well, it can be quite serious, particularly in people who are immunocompromised. What are the benefits to you of taking an action? Well, you're not going to infect yourself or other people. What's one of the barriers to action in washing your hands? Well, one of the barriers is how long is enough? So think about those posters that you might see in a bathroom. What's a piece of advice that you sometimes see that encourages you or helps you to get past that barrier? And if you think you know what it is, just type it in the chat right now. What does a poster like that suggest that you do so that you have washed your hands sufficiently to be able to deal with the challenge of infection or disease? If you think you know that, yeah, Jonathan, there you go, sing happy birthday, exactly right. And what does singing happy birthday do? Well, first of all, it gives you a time because you sing happy birthday to you, happy birthday to you. Secondly, it kind of makes it fun. You're no longer focused on the chore of washing your hands. You're focused on just the enjoyment of the experience. So this is the health belief model at work. Very, very common theory, very widely used. It can be applied at an individual level as well, but it's certainly something that we tend to see widely used as the basis for public health campaigns. There's a bunch of others too. You do not need to know every single theory of health behaviour change. it is important to understand the principles that sit underneath all of those. So what do all of these theories have in common, regardless of which theory that you look at? Regardless of how long it's been around. Some of our theories of behaviour change have been around since the 1950s. And of course, the principle of incentive for health behaviour change has been with us essentially since human beings have been alive. And some of those theories are much more recent than that. You know, for example, the BJ Fogg theory, which is only a few years old. So the things that are common to all theories of behaviour change: number one, motivation to make a change. Number two, behavioral and environmental interaction. In other words, thinking about how the context that the person is living in starts to shape their own individual choices. Number three, the idea of moving through stages of change. You might have heard of this as readiness to change, or perhaps you've even heard the terminology, the trans-theoretical model of change. Number four, the notion of self-efficacy. Number five, the idea of goal setting, a principle common to all theories of behavioural change. And number six, the importance of social connections and influences. So what I want to do now is take you through each of these areas, share with you a little bit of the background to each of them. I also want to share with you some questions that you can ask in clinical practice, some ways that you can think in clinical practice that you can go out and immediately apply, regardless of whether you've been trained in behaviour change or not. And as I'm going through this, as I said, please feel free to type a question in the chat if there's anything that you want to understand in more detail. One of the things that's missing from all of those theories, of course, is the practice of how we do that. So the how-tos, the skills, the tools, how to measure progress, and very importantly, how we support someone to sustain a behavioural change. So these gaps are some of the things that I want to address with you right now. I want you to be able to walk away from this webinar with some ideas about things that you can do. Just as an aside, most of the research that we have on behavioural change focuses on starting behavioural change. And in fact, earlier this year, some colleagues and I published a paper in Mayo Clinic Proceedings on exactly this topic, which really addressed the idea that there's currently a lack of research about how behaviour change can be sustained in the long term. We certainly have insights and ideas about how to support behavioural change, and the process of health coaching has embedded within it some principles that can support a person to sustain behavioural changes. And at the same time, we don't currently have a broad base of empirical data that really summarises neatly what the principles of sustained behavioural change are. So let's start, and we'll go through each of these factors one by one. And there'll be time for questions at the end, of course, and there's time all the way through. So the first factor was motivation, and I've shared with you a reference here. All these references are repeated at the end as well. And Samanika, I'm happy for people to have this slide deck. I can send it to you afterwards, so people can dig into these references also. The first is motivation, and the principle of motivation is best embodied in the flagship text, Motivational Interviewing, by William Miller and Stephen Rolnick. It was just turned into a 4th edition last year. So it's been around for many, many years now, decades, in fact. The 4th edition was published last year with some pretty significant updates. So if this is of interest to you, then I'd encourage you to get hold of the most recent edition, particularly if you already have some familiarity with the concept of motivational interviewing. One important thing about motivational interviewing that I want to address here is that motivational interviewing originally emerged in the context of substance use and substance misuse, so drugs, alcohol, and so on. It's a very, very valuable principle to understand. And the practice of motivational interviewing is a valuable practice, particularly for people who are ambivalent about change. Ambivalent meaning there's part of them that wants to engage in a behavioural change, and there's another part of them that sees some pretty good reasons not to make any changes at all. Motivational interviewing isn't so useful once your patient or client has established themselves on a trajectory of fairly sustained change. Then we need to turn to some other principles to support the maintenance or the sustaining of that change. But certainly early on, when someone's uncertain about a change or ambivalent about a change, motivational interviewing is fantastic. So, how can you support your patient to connect with the sources of their own motivation? What's going to internally motivate them? You might recall when I asked that question about 100 push-ups, a couple of people said straight away, absolutely, I would do 100 push-ups. I hadn't even offered an incentive. So those people have a strong internal motivation. They like doing push-ups because they like doing push-ups, no other reason. The more money I offered, the more people said that they would do push-ups. So for those people, the money is the thing that they like, and they're prepared to suffer the pain of push-ups to do it. Ideally, we want to move from that external motivation to an internal motivation. And these are the sorts of questions that can support your patient to connect with their own internal motivation. Asking your patient in relation to making some change, what's important to you about this? Your patient might say, well, I want to lose some weight. I want to stop smoking. I want to cut back on drinking. You know, I want to sleep better, something like that. What's important to you about this? Another useful question can be to invite your patient to think about the future. What will you be able to do when you've achieved this thing that you're talking about? Your patient says, well, I want to lose some weight. Wonderful. What will that mean that you can do in your life? And in asking that question, you're learning about some things that are important to your patient. In other words, you're learning about the why that sits underneath the action of losing weight. A variation on that is, how will your life improve when you lose some weight or when you make this change? Or if you prefer, a question that invites your patient to think significantly into the future, what would you like to be able to do in your life 10 years from now, or 5 years from now, or 2 years from now, that you can't currently do? And all of those questions invite your patient to go a little bit deeper and not stay just with the idea of, I want to make this change, I want to do something different, but it invites your patient to reflect on why they want to do that, what's important about that. And the answer to those questions is motivation. That's what's going to motivate your patient to make that change. So that's principle number one that you will find across all theories of behavioural change, regardless of which one you look at. The second principle is this idea of interaction between an individual's behaviour and their environment. And the reference I've provided for you for this, you'll see, is nearly 80 years old. It goes back to 1946, Kurt Lewin. It's a very old reference, but it's such an important piece of work that really articulates this idea of the interaction, if you like, between a person and their environment. And in fact, Kurt Lewin had a formula which he devised, which simply says that a person's behaviour, the outward behaviour we see, is a function of the person and their environment. So if you're interested in understanding the origins of this principle, then I encourage you to go to Kurt Lewin's work. Thinking about that principle, the interaction of the person and the environment, what are some ways that you can leverage that principle in clinical care? Well, one way is to be curious and ask your patient, what do you already have in place to help you here? So if your patient is expressing a desire to make a change, what's already there for you that you can make use of? How have you been successful in making other changes? What have you done in the past that's been successful? Or who can support you in this challenge? So that's two dimensions of resources there, two dimensions of environment. One is focusing on the idea of past successes. The other is focusing on the idea of perhaps systems and structures. This third element is focusing on the idea of people in the environment who might act as a support. And this final question, what might you be able to change in your surroundings that could exist, is an important question because it invites your patient to think about the way in which they can modify their environment. Environment's an interesting concept because a lot of our environment we can't modify. I live in Madrid, Spain, where in summer it's 42 degrees during the day. I cannot change that. It's 42 degrees, for every day for about 4 to 6 weeks in a row. I can't change the 42 degrees, but there may be some things I can change about the immediate part of my environment. For example, I could choose to walk in the shade. I could choose to wear a lighter shirt. I could choose to put on sunglasses. I could choose to walk through a sprinkler. So I can modify some immediate things about my environment, even change a significant part of it. The other important thing about this particular principle of behavioural change is that it's exemplified in a body of research called the Common Factors Research. The Common Factors Research focuses on the principles that support positive outcomes in behavioural change. And the most influential principle is the set of resources, skills, and abilities that your patient has. That counts for far more than your own knowledge or my own knowledge as a practitioner. It counts for far more than any advice or information you might give your patient. The more that you can support your patient to connect with their own set of tools, resources, skills, abilities, the more likely they are to experience a successful outcome in their own quest for a behavioural change. So that's the second principle. The third one, the stages of change idea, and I've referenced, of course, the most important work here, the most influential work, a description of the trans-theoretical model of change by Prochaska and De Clementi. Again, this goes back many years. You might know it as the trans-theoretical model of change. You might know it as the readiness for change model. In short, it describes a process through which all of us move in relation to every single behavioural change that we might make, and it starts at the idea that we don't even have an inkling that this change is important to us. We haven't even started to consider the possibility of change, right through the beginning of considering it, contemplating it, thinking in more detail about it, planning it. Exactly right, Fahad. Pre-contemplation and contemplation, the first two stages of change. Starting to plan it, starting to put it into action, and then keeping it going into the long term. It's a wonderfully useful model, and as the name suggests, it's trans-theoretical. So it really doesn't matter whether you're talking about the health belief model, the theory of planned behaviour, the theory of reasoned action, or any other particular theory of behavioural change. This idea tends to hold true across all of those. So in clinical practice, some useful ways that you can explore this with your patient can be by asking some very, very straightforward questions. You heard me ask a question like this right at the very start when I asked you to rate your enthusiasm about being here on a scale from 0 to 10. So the two dimensions of readiness to change can be summarised by the importance of the change that you see in question number 1 and the patient's confidence to change that you see in question number 2. So if you ask your patient on a scale from 0 to 10, where 10's the highest, how important is it for you to make this change right now? Not tomorrow, not in the future, not next month, not next year, but how important is it right now to make the change? And then similarly, on a scale from 0 to 10, where 10's the highest, how confident are you of making this change right now? Not next month, not next year, but how confident are you that you can start this process right now? The higher your patient's score on each of those scales, the more ready they are to take some steps towards change. It's that simple. So getting that sense straight away from your patient is helpful to you as a practitioner because it'll give you some immediate insight into your patient's readiness for change. In the event that your patient has a lower readiness for change, and I've suggested using 7 out of 10 there as a threshold. So if your patient is scoring higher than 7 out of 10 on both importance and confidence, that's a pretty good indicator that they're ready to take an action step towards making a change. If they're scoring lower than that, then a really useful question is, what would a half-point increase look like? And the importance of the half-point increase is that we're engaging in a strategic approach there, which is called restraining change. And restraining change is important because it's much more useful for a person to take a series of small steps, which they can achieve on the way towards a change, rather than take a gigantic leap, which may not be so successful. So if we're curious about a small increment, what does a half-point change look like? And invite your patient to describe that. Then they're more likely to generate some ideas that represent something that's gradual and achievable for them. So that's the third factor, the idea that we all move through different stages of readiness for change. And even though we might be saying, I'm sick of being overweight, I'm sick of waking up every morning coughing from smoking. I'm sick of the way that I feel, when I wake up in the morning or when I go to bed at night. That doesn't necessarily mean that your patient is ready to take action right now. So it's important to establish this as you talk to your patient. Principle number 4, self-efficacy. This largely comes from the work of Albert Bandura. Albert Bandura was a preeminent American psychologist who only passed away during the pandemic, actually. And he spent many years articulating ideas around self-efficacy. Self-efficacy is fundamentally the principle that you have both the skills and the capacity to make a change. In other words, the competence, and you also have the confidence to put that into practice. So Bandura articulated 4 pathways to change, or 4 pathways to self-efficacy. And I've turned each of those pathways into a question that you could ask your patients. The first one is, tell me about a time when you've had a similar success. This is the principle of incremental mastery. So a mastery experience. Having had an experience of success, we're more likely to try something again. So by inviting your patient to reflect on a time when they've been successful, they're going to connect their experience with some skills, some resources, some good feelings that they had about doing that. Second question, who's your role model here? That's another pathway to self-efficacy, being able to model our behaviour off someone else who has done something similar. The third question, what are the reasons or the needs that you have for change? Very important, because the reasons and the needs, of course, represent at some level that idea of motivation. And then the final question, what would it feel like for you to achieve this? This is a wonderful question. One of Bandura's pathways to self-efficacy is what he called physiological and affective experiences. You can demonstrate this for yourself right now. Think of something that you've done in your life that was a really significant achievement for you. Maybe you ran a marathon, maybe you ran a half marathon, maybe it was the first time you ran 10 kilometers, maybe it was the first time you hit a certain body weight that you were trying to get to, or a certain body composition that you were trying to achieve. Maybe it was so many days in a row of eating a particular diet, whatever it might be, or it might have been an academic achievement. Maybe the time when you found your PhD was being conferred, when you graduated from university. Whatever that experience of success was, think back to the feeling that you had in that moment. Think back to the emotion that you experienced, and maybe even, if you can, the feeling that you had in your body. That's a really powerful cue for success, and a really powerful cue to help you to continue in that behavior. If you had that flush of pride and accomplishment and satisfaction, and you almost literally felt your body buzzing with excitement, they're the sorts of things that we want to invite our patients to reflect on in their experience. And that's a wonderful pathway towards self-efficacy. So lots of questions that you can engage your patient in there to help them connect with those successes. Principle number 5, goal setting. Now, you might be familiar with SMART goals, S-M-A-R-T. SMART goals are fairly ubiquitous. It's not a bad way of setting goals. There are some criticisms of SMART goals. One of those criticisms is that SMART goals don't have any theoretical or conceptual basis to them. And another criticism is that there's not universal agreement on what each of those letters stands for. So, for example, S for specific, M for measurable. Some people say A is achievable. Some people say A is actionable. Some people say R is relevant. Some people say R is realistic, and so on. There is a very, very good theory of goal setting, devised by two people called Locke and Latham. You can see it's been around for a number of years, 35 years now. It's a wonderful theory of goal setting, and it has five principles to it. The first one is the principle of clarity. Is the goal clear enough so that the patient can act on it? Is there enough clarity there in the goal? The second principle, is it challenging enough for them? It's good to have goals, and it's good to have goals that stretch us a little bit. You don't want to set goals that are too easy to achieve, because if they are, you don't really have to learn anything different to apply it. You don't have to push yourself. You don't have to extend your capacities. So we want goals to be challenging enough that they stretch us a little bit. The third principle in goal setting theory is, does your patient have an investment in the goal? In other words, is this something that you asked your patient to do, or did the patient co-create the goal with you? Or even better, did the patient come up with the goal themselves? The more invested your patient is in the goal, the more likely they are to engage in it. Fourth principle, what are the feedback mechanisms that are in place? So how do you measure progress, and how do you support your patient to measure their own progress? One of the ways of doing that is using a scaling question. So, for example, if 10 out of 10 represents completion of the goal, where are you right now on a scale from 0 to 10? And the final principle in goal setting theory is to make sure that complex goals are partialed out into less complex goals. So if your patient says, you know, I want to run 10 kilometers, but in order to run 10 kilometers, they need to buy some running shoes, buy a hydration kit, buy some running attire, buy a gym membership so that they can train and so on. It's important to break that down into all those individual goals. Otherwise, the goal of running 10 kilometers itself is just too overwhelming. There's too many component parts that have to be tracked. So much better to partial it out. So wonderful theory of goal setting, and I encourage you to dig into that. Final principle, which comes from the work of Kelman, the idea of social connections and social influences. You can see 3 principles from Kelman's work here that lead to attitude change. The first is the principle that embeds the idea of goals and rewards and even contracts that you might make. Now, we know that these tend to be external incentives, and we've already said external incentives can work in the short term, but they don't necessarily work in the long term, but they may be a useful way of getting started. The second principle in social connections is what's called the therapeutic alliance, your relationship as a practitioner with your patient. So this is a measure of how warm you are, how interested you are, how curious you are about your patient, how engaged you are, how interested you are in your patient's successes, how compassionate and concerned you are, how much your patient feels like you're someone who is very, very trustworthy and also invested in them and their best interests. And the final principle in this is internalization. So this is to do with your patient's own personal beliefs, their own values, their own attitudes. And those questions that I shared with you at the beginning, what's making this important to you? What's important about this change to you? Those questions can often bring to the surface some of these personal beliefs and personal attitudes and personal values. So those questions can do double duty across a couple of these different principles and can be useful to harness that as well. So 6 principles that we've covered, common to all theories of behavioural change. I've given you 6 references, 6 different references there that you can dig into if you want to go back to some really valuable source material. A bunch of questions that you can ask in clinical practice that support you to put those principles into practice in your work with patients. There's all those references there. I've included at the start, you can see there's 2 references at the start by Gary Sforzo and a number of other people. Those 2 papers published in the American Journal of Lifestyle Medicine are about the efficacy of health coaching as an intervention. So they're published during the pandemic, and they are essentially reviews or compendia of all the available evidence about health coaching in relation to specific chronic diseases, diabetes, hypertension, hyperlipidemia, and so on. So if you want to get a sense of the value of health coaching, then I encourage you to dig into those references as well. Well, there we go. A walk through some principles of health behaviour change, some ideas about how you can put them into practice. Please feel free to connect with me if you want. You can scan that QR code. There's some other details. I'm on LinkedIn as well. If you're not connected with me on LinkedIn and would like to be, please feel free to do that. Samadika, I'm going to pause there and let's see what questions and discussion might follow.
Thank you very much, Simon, for that very insightful and very clear presentation on how to initiate and sustain health behavior change. We will now open the floor for questions. I can see Samadika has raised his hand. Oh, no, sorry. Okay. You can ask questions from Simon. Meanwhile, I'll just raise some of the questions that have been raised on the chat. One of the themes that was raised is about the efficacy of health coaching and the effectiveness of implementing these strategies. I know you did mention about a reference on that. But in general, how effective is implementing these strategies? Because I know in practice, we feel that, even though we sometimes encourage our patients, but in the end, we don't see results, and that can be a bit frustrating for the practitioner. How can we overcome this?
That's a great question, and there's actually a couple of questions in there. So yes, it's possible that you can work with a patient towards some behavioural change. What was the phraseology you just used, Rukshanie, about the progress? Not seeing.
Not seeing the results.
Not seeing the results. Okay.
Yes.
Okay. So there's a lot of things that could be going on there. One thing is, or one possibility is that while a big result may not be achieved, there might be some smaller results that can be observed and can be built upon. So this goes back to the idea of self-efficacy and looking for small successes, small wins to build upon. This could also be because of the idea of readiness for change. So perhaps the patient is working towards a behavioural change that they're not yet ready for. It could also be to do with where that change is being suggested from. So if it's the practitioner suggesting the change and the patient doesn't really have a strong investment in it, we saw that principle in the presentation, then the likelihood that they're going to engage in that change is reduced as well. So there could be a lot of things that are going on there. The trans-theoretical change, the trans-theoretical model of change, the stages of change model, is one of the best tools that I know of for avoiding clinician frustration. If you can internalize the principles of the stages of change model, and if you can target what you do to the patient's stage of change, it stops you from getting overly invested in change and then frustrated when it doesn't happen. So that could explain it from, or that could be some of the explanations that might underpin why you might not be seeing the outcomes in a particular patient. The other part of it is about the efficacy of health coaching, and those references are there. Health coaching is efficacious. There's just no question about that in the research, and it's not a panacea. It's not the case that a health coaching approach simply guarantees a particular outcome for a particular person, but it does represent a means of supporting patients to engage in what's often a difficult and challenging change in a way that's most likely to lead to a successful outcome for them. So I hope that's answered that question in a useful way, Rukshanie.
Yes. Another question that has been raised is the inertia of initiating change. A lot of people say that they don't have time or they are tired. How do you troubleshoot that initial inertia to initiate change?
Yeah, what a wonderful question. What a wonderful question. So first thing to do is to recognize the stage of change that's represented by that. If your client is saying, yes, I would like to, but I don't have the time, or I don't have the energy, or my kids, or my work, or my husband, or my wife, or whatever, then what we're hearing is ambivalence. Yes, I would, but I'm not so sure. Ambivalence means the person's at the contemplation stage of change. In other words, they're not yet ready to embark on a course of action. So the most important thing to do there is don't start giving your patient things to do, because they're not likely to do them. They're saying, well, yeah, I'm interested, but there's a bunch of things here. One of the really useful strategies that you can apply as a practitioner is to help your patient to sort those perceived barriers. So if they're saying time, money, I don't know, kids, whatever, then work with them to identify which is the most significant barrier, which is the biggest one, which is the next biggest one, and the next, and keep working all the way down until you get to the smallest barrier that they see. Once you've identified the smallest barrier, then have a conversation with them about ideas they have about how they might overcome just that small barrier, just that smallest barrier. This is building on the principle of self-efficacy, having a small success in one area, which might then be able to be applied in another area, and so on. So it often involves, a progressive stepwise approach and patience to be able to support your client to continue to explore both the benefits of change, the disadvantages of change, what might they have to give up if they make a change. And we all have to give something up when we make a change. There's no question about that. In addition to being able to just steadily address those barriers along the way.
Okay. Thanks, Simon, for that. There's another question about, this is quite a broad question, about communication in different age groups, work groups, socioeconomic levels. Is there like a reference that we can use on how to communicate in different scenarios?
Great question. There's not a reference that I know of, but if someone here does know of a reference, then it would be great to hear about it. The principle, I can share with you the principle that I use myself in clinical practice, and that principle is to listen to the language that my patient or client is using and use that style of language with them as well. I'm a psychologist. All of us here are professionals of one sort or another. Psychology has its own unique and discrete language, terminology, and so on. I don't use that terminology in clinical practice necessarily because it's not the way that my patients and clients speak, and it's not terminology that's going to be familiar to them or necessarily easy for them to understand. So, for example, I would never say to a patient, so it appears that you're in the pre-contemplation stage of the trans-theoretical model of change. Not going to mean anything. I might say, it sounds like you have a lot of doubts about whether this change is going to be valuable for you. So listen to the language that your patient uses, translate your own professional language into everyday language. And that goes a long way also towards building that therapeutic alliance that we talked about, really building and cementing the connection that you have with your patient. I'm sorry I can't be more detailed than that, but I hope there's something useful in that response.
No, I think you answered the question, Simon. There's a question on the chat.
Are these health behaviours taught at school level? You will find if you take a course in I don't know, behavioural change or health psychology or something like that, you will probably find some of these taught. Not all of them. There's too many, of course, and there's not necessarily value in knowing every one of them. And I love the next comment. These ideas need to be hardwired, yes, and they certainly need to be hardwired for us as practitioners, so that we can distill, if you like, all these principles that we've been talking about and be aware of the importance of these 6 principles of behavioural change, so that we can apply them in daily clinical practice. Jonathan, sounds like the physician's clinical relationship may well be a block to establishing an effective health coaching relationship. Yes, sometimes if the clinician leans too heavily on clinical expertise, knowledge, what's the word I'm looking for? Um, I can't quite find the word I'm looking for, but in a sense, their own expertise, their own kind of level of level of practice. Yes, some of the clinical jargon as well. If the clinician leans too heavily on all of that, then it does interfere with the therapeutic relationship, and it interferes with all relationships. Think about maybe if you go to the dentist, if the dentist is just using dental jargon, if you go to your accountant and the accountant's using technical economic jargon, all of that interferes with our capacity to understand and apply these ideas to our own situation. So one of the most important jobs that we have as clinicians is to be translators and interpreters. It's our job to make sure that all of that knowledge, all of those skills, all of those clinical ideas that we've been taught and we've internalized, we can translate into everyday language so that we can build and maintain that therapeutic alliance or that connection with our patients and clients.
Building up on that question, I just want to ask your thoughts, Simon, on what is the impact on policy change on promoting health behavior change? For example, we know that now when it comes to smoking, there is certain information given, and then it's held in under lock and key. So the ability to and the taxes were raised, so people are unable to access cigarettes as easily. So likewise, is there any impact on creating policies, as well as maybe teaching children at a younger age about health behavior change? How impactful are these things? Do we have any insights on that?
Yeah, what a wonderful question. What a wonderful question. And public health is not the main area that I work in, but I do have a broad understanding of some public health principles. So I'll share with you what I know and what I understand. First of all, well-crafted public health campaigns are generally successful. We've got lots of evidence for this across time. Think about public health campaigns for communicable diseases. In fact, one of the most successful public health campaigns in the history of humanity was the HIV/AIDS campaign in Australia in the late 1980s and early 1990s. It was credited with radically altering the behaviour of the population at the time. Tremendously successful public health campaign. The more recent COVID-19 pandemic public health campaigns that we saw being rolled out around the world also, generally had a strong shaping influence on people's behaviour. Public health campaigns work. Smoking is a great example. In Australia, where I came from, the cost of a packet of cigarettes in Australia is now in the order of nearly, I think it's nearly $50 for a packet of cigarettes. That price disincentive works very strongly to discourage new smokers. For people who are long-term smokers, it discourages some of them, but if they have the financial resources, $50 they're not going to worry about. They'll pay the $50 and keep smoking. But it does discourage new smokers. You might be aware that New Zealand has introduced legislation to say that if you are born after a certain date, and I think it's somewhere around 2003, 2004, you will never, ever be able to buy a packet of cigarettes in your life. So those sorts of campaigns will be successful. They have a long lead time and so on. Interestingly, so there's a financial tax on tobacco that acts as a disincentive. Interestingly, some jurisdictions have tried a sugar tax on carbonated soft drinks, and the sugar tax generally hasn't been successful, and that's possibly because soft drink is so inexpensive anyway. Even a $1 bottle of soft drink, even if you introduced a 100% tax and made that $2 a bottle, most people will probably go, oh, okay, well, you know, that's a bit of a nuisance, but I'll pay $2 a bottle. It's just not enough of a disincentive. So we can't have a one size fits all as far as public health campaigns. We need to think about what's going to work here. One of the things that does work, of course, is education from a young age. So helping young children to understand the importance of looking after their own health, the principles of good health, how to put those principles into practice. Yes, those things absolutely make a difference. Again, they're not a panacea. It doesn't mean that if we start some, school-based education campaign, that we're going to get 100% compliance or 100%, behavioural change in a particular direction. But we will be shaping the general trend of behaviour over time. Yeah, I hope that's based on my limited public health knowledge. I hope that's a useful response. A couple of questions in the chat I can see here. How do health models of change account for cultural and social factors? Wonderful question. And the short answer is not all of them do. Not all models of health behaviour change do account for social factors. And that's why I've extracted that idea of social factors that you find across some of them. So Lewin's ideas about the person's behaviour being a product of the individual and the environment does help to take account of that. The notion of social determinants of health, of course, is a really strong principle that sits behind cultural and social factors and helps us understand the systemic relationship between individual change and societal functioning. But not all models of change do that. The trans-theoretical model of change, for example, is a good example of a model that tends not to take account of cultural and social factors. It's more focused on at the individual level. In my experience, why don't people have sustained or consistent internal motivation? Yeah, good question. Again, there can be a lot of reasons that might explain this. But one possible reason is that internal motivation changes over time. So, for example, I'll share with you a personal anecdote here. I've been getting back into running, having been absent from running for quite some period of time. My initial internal motivation in running was because I wanted to see an improvement in my VO2 max score, which I will share with you was already pretty good, but I wanted it to be better. I saw that improvement. That no longer is my internal motivation. My internal motivation now is I love getting up in the morning and running. That's it. That's all I need at the moment. I just enjoy going running in the morning. So internal motivations shift across time. And if as practitioners, we don't follow those shifts with our patients, then it may mean that our patient's internal motivation is sitting over there, not being noticed by anyone, whereas we're still focused on what it was back here. So one of the things that's important to do in clinical practice, of course, is to keep track of what it is that's motivating your patient, and the questions to do that, of course, are what's making this important to you. What do you want to be different as a result of this? Those sorts of things. So I hope that's answered that. I might.
Are you around?
Stop the share.
All right. Thank you very much, Simon.